Color vision testing is online smartphone app an alternative to traditional Ishihara handbook. The assessment of chromatic discrimination ability and diagnosis of any perceptual deficiency is color vision testing. It's a part of functional assessment of the visual system by ophthalmologists. With technological advancements, digital version of commonly used Ishihara is now available on online platform. Cone photoreceptors in retina help in color perception. Three types of photoreceptors corresponding to three primary colors result in trichromacy: red, blue, and green. Not all people possess trichromacy, and some are partially or completely colorblind. The most common form of color deficiency is red-green deficiency: protanopia, protanomaly, deuteranopia, or deuteranomaly. Color deficiency may be caused by acquired diseases like cataract, glaucoma, trauma, or medication, or aging. The Ishihara test is a color perception test for red-green deficiency, which is the first successful vision test called pseudo-isochromatic plates. There are several test designs: introductory plate having 12, which is visible for all; transformation plate, which color vision deficient cannot see the differentiate and only normal people can see; vanishing plates, only people with normal color vision can recognize these figures; hidden digit plates, only the people with color vision defect can recognize these figures; diagnostic or classification plates determine the type and severity of color vision defect; tracing or pathway plates, where the subject is traces a visible line across the plate. With advancement in smartphone technology and medical software applications, physicians are increasingly incorporating it into their daily life. Smartphone applications has advantages like it is affordable, accessible, prevent delay in patient care, solve the problem of shifting colorimetric values with aging of the physical color plates, interprets its result by differentiating between color deficient and normal person. However, it is unable to classify the type of the color deficiency. In our study, it was a random observational study. We took 120 participants of age 18 to 30 years visiting our outpatient department. An informed consent was taken. Visual acuities as distant and near were assessed. Ophthalmoscopy performed to rule out any ocular pathology. People with ocular pathology or visual acuities worse than 6 by 6 were excluded. Participants with specs or contact lens were asked to wear those. Room illumination and standard distance were maintained. 2 tests were conducted, first right and then left eye, and both handbook and digital version were used randomly. 9 error or more in the Ishihara were categorized as red-green deficiency and failed the test. We found the result: 52.5%. We took 52.5% male and 47.5% female. 4 out of 63 men were color deficient. The sensitivity and specificity of our digital version were found to be 100%, as Ishihara was the standard for comparison. In various responses, for 4 men who failed screening test on digital version were recorded, were compared with the handbook. In our study, sensitivity and specificity of digital version of Ishihara as compared to the smartphone application is 100% and 100% respectively. Combined sensitivity of transformation and vanishing plates in the digital version of Ishihara makes it an efficient screening tool due to red-green color vision deficiencies. In several studies, like in Hoffman and Mazzoni study, they found traditional Ishihara test compared to computer-based screening system. Both were efficient, even though spectral emission of the monitor and reflected daylight with traditional Ishihara plates, there was correctly distinguished subjects with color deficiencies from those without any. Rodriguez found 20% of the normal trachomers failed the test, suggesting the limitations in its application. In accordance with Hoffman and Menozzi, the present study confirmed that the digital method was able to distinguish between participants with and without color deficiencies. Coming to conclusion, the digital smartphone application version of Ishihara is a possible alternative to screening for color deficiency in unavailability of the traditional Ishihara handbook, and also provide a convenient self-screening alternative to in-office assessments, or when the test is required to be done by untrained professionals. However, test has the limitation as it was not able to accurately detect the severity of the deficiency. In case of participants who are possibly identified as having color deficiency, a thorough in-office assessment is required to be carried out by appropriately educated professional using the traditional Ishihara handbook in the standardized conditions. Thank you.
Are you prefer direct ophthalmoscopy first or indirect ophthalmoscopy first, or color vision earlier.
So
In your practice,
Yes, sir.
suppose one patient in front of you, are you prefer to do ophthalmoscopy first or color vision first?
So we'll do color vision testing first, then we go for ophthalmoscopy.
Yes.
What was the color vision app that you had used? You had not, I think, mentioned it in that.
So there we used random apps. There was no specific app used. It was a Ishihara testing app named.
It was not the same app you'd used in all
So we
patients.
used the same app, but it was Ishihara testing app which was available online. It is shown here.
So Ishihara, unfortunately, is not there to make the app. So somebody would have. But anyway, sure. Just remember, always the testing modality must always be mentioned in your presentation or wherever you write. Okay?
Yes.
Because otherwise, how will we, if somebody wants to recheck the values of your study, how would be? The only downside of your study I can see is that the number of patients who tested abnormally on the Ishihara were only 4.
Yeah.
So that's a very small number to actually test the digital app on its inability to pick up color vision
Yes,
deficiency.
sir.
But anyway, it's a very nice and very important thing. Thank you. I think we'll go on to the next. Thank you.